All right, guys, welcome to the quarantine classroom. This will be an audio lecture that goes along with the PowerPoint. You can take your notes out if you want. I'll tell you things to write down that are important. The reason this chapter is important is because in EMS, with the patients we see, substance abuse is a problem. It's something we're going to have to struggle with, especially in America. So it's really important that you're familiar with some of these substance abuse issues. And also poisonings, like accidental poisoning, stuff like that. So, all right, so before the FDA was created, there was really no rules about what went into what. But luckily now, medication is a lot safer. So, ingested poisons, more than 80% of poisonings are caused by ingestion. So that's something you might see on the test, okay? So the vast majority of poisonings occur from ingesting someone's, like, eating it. You might even see some of the signs and symptoms around the mouth. Okay, but generally, nausea, vomiting, abdominal pain, that all kind of makes sense. Diarrhea, abnormal or decreased respirations, loss of consciousness, and seizures. So all of those things can happen from ingested poisons. So if there's no real explanation and a patient is having these things, you might want to ask about maybe some of the things they ate. So best you can, identify the poison, which is tough depending on like where the person is and what's going on, but if you can identify it and call it up to medical control or even the National Poison Center, and they'll help you out with the correct way to manage that issue. So dilution, the rhyme is the solution to pollution is dilution. Okay, so just dilute everything out, whether it's on the skin or whether someone ingested it. For the most part, it's lots of water is going to. However, if it's a little bit more extensive, there's a thing called activated charcoal. So it's ground charcoal mixed with some water, and it binds to the poison, all right? So that's another keyword, is binding. It doesn't absorb the poison, it doesn't neutralize the poison, it binds the poison, okay? The exception, though, is if they have ingested an acid, an alkali, or a base. You do not want to give activated charcoal. And then, of course, if they're unconscious, they can't swallow or anything, so we don't want to be putting anything in their mouth if they're unconscious. But activated charcoal works for most poisonings except acid, alkali, and bases. And that's because we actually don't want that in the body whatsoever, and so we'll get that out a different way. So activated charcoal looks like that. It's pretty gross looking, which is why you see that bottom point, which is why we want to cover it in a cup and give a straw, because we don't really want the patient seeing the gross thing they're drinking, right? The usual dose is 25 to 50 grams for an adult patient and half that for a pediatric patient. So that is also something that is testable, okay? So know what activated charcoal is, when you can and can't use it, and the dose. Now, in the past, we used to give syrup of ipecac, which was this like vomiting agent, and basically as soon as that person drank it, they were throwing up everywhere. But we kind of gone away from that because sometimes people will throw up and then inhale the vomit. Obviously, we don't want stomach acid in our lungs, so we don't do ipecac really anymore, okay? It's pretty much activated charcoal from now on. All right, inhaled poison. So this is a different route of transmission. This is if a person inhales the poison. And some of these substances, like carbon monoxide, are very poisonous but not irritating. The patient won't even know that they're exposed to it. Whereas other gases like chlorine and ammonia and some of those things are very irritating. They're going to know right away that they inhaled something. So overall, though, the signs and symptoms are going to be respiratory distress, dizziness, cough, headache, hoarseness, confusion, chest pain. So if you see any of those symptoms, maybe start asking questions about, well, did you breathe anything in? Were you around any chemicals? Just a little bit more information with that. Carbon monoxide is actually a pretty common cause of poisonings, usually from improperly ventilated heating appliances, or of course just burning stuff like smoke. Burning buildings, burning couches, burning tires, all that stuff can be pretty toxic. So carbon monoxide, initially the patient won't even know that that's going on. However, they will have a headache, nausea, disorientation, unconsciousness, and maybe even some flu-like symptoms. So they're going to report that. They're not even going to know that I breathed something in. They're just going to say I'm reporting these symptoms. For a team safety thing, if there's a few patients who are all in the same area, who are all complaining of the same thing, start thinking that maybe it's not a safe environment. The reason we care about carbon monoxide so much is, unfortunately, carbon monoxide can bind with hemoglobin and it makes a carboxyhemoglobin. And once that hemoglobin is stuck with the carbon monoxide, it can no longer do oxygen. So on the pulse ox, which is that little thing you put on the tip of the finger, it'll say 100% saturated. However, that just means it's saturated. It doesn't mean oxygen. That device is not really that good at telling if it's carbon monoxide or if it's oxygen or nitrogen or whatever. It just can tell that it's saturated. So that's why carbon monoxide is so dangerous, because you effectively can't use the oxygen you're breathing. So in that event, the easiest treatment is just remove them, just get them out of there. You can do CPR and oxygen and stuff if you have to, but for the most part, a person's going to start feeling a lot better immediately once they get in that environment. All right, injected poisons, we're kind of talking about two different things here. It's going to be animal bites and stings, but also toxic injections, heroin, stuff like that. But either way, you're going to see some obvious injury site, either from where the needle went in or like the bite marks. It's going to hurt, it's going to be swelling. These red streaks radiating from the injection site, that is called phlebitis. That's where all the veins are really irritated. They're going to be weak, they're going to be dizzy, they're going to have a lot of pain at the bite area, and it's probably going to be pretty itchy because the body's dealing with toxin. So if someone's been bit or stung, you want to keep the patient calm and quiet. There's some evidence that a light constricting band might be used if in severe swelling, but for the most part, you're not wrong, just to apply some ice and take them to the hospital. Now, the one thing we have to talk about is anaphylactic shock. So that is when someone has some sort of bad reaction to either the bite or peanuts or latex. You've heard of those things. And the thing we got to look out for on anaphylactic shock is itching, hives, swelling, wheezing, respiratory distress, some weakness, and hypotension. Hypotension is in all caps because that is the hallmark of anaphylactic shock. They're going into shock because their blood pressure is low. So if there's a question on the test about anaphylactic shock, low blood pressure and respiratory distress is going to be the main things we're looking for, okay? They're going to have rapid weak pulse, rapid shallow breathing because their body is struggling to keep up with this poison. And at our end, we're going to maintain the ABCs, airway, breathing, circulation. We're going to give oxygen if we have it, and we're going to elevate the legs. Now just remember though, elevating the legs works temporarily, but the second I lower those legs, I'm right back to where I was. So the idea is that I lower the legs and some of that blood is going to stay in my core. And so it works, but just understand that it's 100% reversible. So if you elevate the legs, you got to keep them elevated. All right, so remove the allergen. Try to, depending on what the allergen is, get it off that patient. Monitor the vital signs, especially that blood pressure. Keep an eye on those ABCs and evac to the hospital as quick as possible. Now, if you have an auto-injector, depending on where you're at, you may not be able to use epinephrine, but if they have an EpiPen like in their purse or whatever, you can use it at that situation. So it just depends on like your district, right, or where you're working. But basically the EpiPen it's epinephrine, which is a synthetic adrenaline, and it directly reverses the signs and symptoms. So that blood pressure problem, the breathing problems, all that stuff goes away with the EpiPen, okay? So it's just like in that picture, it goes right on the side of the leg. It's the size of a big Sharpie. You place it against the thigh for about 10 seconds or so, and that person should start to have relief pretty quickly. Now, snake bites. There's only 4 kinds of poisonous snakes naturally occurring. Like in America, of course, there's going to be people who have python or cobras and stuff in their house, but for the most part, rattlesnake, cottonmouth, copperhead, coral snake is what we're worried about. Here in Idaho, we're really only worried about rattlesnake, so we're lucky in that way. Rattlesnake, cottonmouth, copperhead are kind of in one camp, and a coral snake is in the other camp. So, and we'll talk about that, but you got to know the differences between the snake bites. So, especially for your rattlesnake and cottonmouth, copperhead, immediate pain at the bite site. It's going to be swelling and very painful. They might faint because of the reaction to it. Sweating, nausea, vomiting, shock. You might have a little bit of a mini anaphylactic reaction there as the body tries to deal with it, but it'll be local, okay? So rattlesnake, cottonmouth, copperhead, think local, and coral snake, think systemic. So the coral snake actually attacks the nervous system. So that can be respiratory distress, slurred speech, paralysis, coma, seizures, all that stuff. So just know that the rattlesnake and those snakes are going to be local issues, like right where the bite occurred, whereas a coral snake is going to be kind of whole body systemic. Basically, same idea though, keep them calm and quiet, have them relax, wash the area in soap and water, treat the patient carefully, maybe use an EpiPen if they're having those issues. Otherwise, they need to go to a hospital and they need an antivenom. So the best treatment for them is going to the hospital. All right, absorb poisons. That's when something you can absorb it through the skin. So you can absorb insecticides like from farming stuff, organophosphates, and we'll talk about that in a little bit, and other toxic industrial chemicals. Some drugs can even be absorbed in the skin. So if you're looking at the area, you might see some traces of powder or liquid on the skin, and the area of that skin is definitely going to be inflamed. So they might even burn the skin, burning, itching, nausea, vomiting, dizziness, and once again, shock. The body is trying to deal with this toxin, and the vital signs can get kind of weird as it does so. So my recommendation is look in the area, try to clean it, and then take them to that hospital. And the thing about cleaning the area is if it's dry chemical, like a powder or something on the skin, you got to brush it off. If you just dump water right on that, some chemicals react very badly with water. So we want to make sure we brush off most of the chemicals we can, then we can start diluting it with water on the surface of the skin. All right, now nerve agents, this is something that's definitely going to be on your test. It's very deadly. These were invented by us. Actually, a lot of it was invented in World War I, and then it was actually further researched and specialized in World War II. So these are chemicals that are designed to kill humans. Some of them within a few minutes. We don't really have to worry about it here in Idaho, but it is a chemical out there that exists, and we do need to know what it looks like. So this is definitely something on your test. The nerve agent symptoms are going to be sludge. Okay, so just try to remember this. And it can also be from organophosphate insecticides, but on the test, I will very clearly explain, they're together. It'll be both of them. So salivation, sweating. Lacrimation just means excessive tearing. I think they use lacrimation because it's like the fancy word, but also they, can use sludge. Urination, defecation or diarrhea, gastric upset, and emesis, which just means vomiting. So basically, our body is a series of on and off switches. Even our gastric intestines, how they work, and our salivary glands and our tearing, all that stuff is kind of an on and off switch. Well, with this nerve agent, when you get exposed to it, all that stuff goes on and it cannot go off. So that's why all of our little automatic processes just go to 10, and all of a sudden you're going to see all those things. Now, nerve agents and these insecticides, these are pretty much the only things can really lead to these sludge-like symptoms. So you got to know it, because if you get a call for a patient with sludge symptoms, that's a huge scene safety thing. That means they were exposed to something pretty deadly, and you got to be careful when you're with it. Now, just like the EpiPen, same idea, except it's different drugs. We want to support the ABCs, but then we can hit them with two of these, Duodote or Mark 1. They're basically the same. It's drugs that help counter the effects of the nerve agent poisoning. And we want to reduce these symptoms and get them to a hospital and then help them climb out of that poisoning. So a weird looking slide, but there's just the instructions. It's pretty much just like the EpiPen, right? Stab it in the leg, give it 10 seconds, monitor the patient. All right, substance abuse. This is the big stuff. This is a big thing we'll have to worry about working in EMS and hospital healthcare in general. This says that about 8.9% of the US population are substance abusers. I think it's way, way higher than that, in part because people don't want to admit that, right? If you were taking some anonymous survey from some random person, they said, do you do drugs? You'd probably say no, right? So I think that number is actually a lot. Now, alcohol, write this down. Alcohol is the most commonly abused drug in the United States. It's involved with traffic fatalities, murder, suicides, domestic violence, everything. It's actually pretty surprising that alcohol is actually still legal, considering all the damage it does. So the real reason we care about alcohol, and it's kind of separate than some of the other drugs, is alcohol is the only drug, basically the only drug where stopping it can kill you. right? Any heroin, any other drug, you stop it, it's going to suck. You're going to go through withdrawal. You're going to have a lot of health issues, but you're going to be okay. However, alcohol is the opposite. If you have someone who's very, very heavily addicted to alcohol and you cut them off cold turkey, their body can die. And it's called delirium tremens. So that's something for the test. DTs is kind of the nickname. It's a severe complication of alcohol withdrawal. All right. And in fact, one reason the liquor stores are staying open during this virus is that some people need alcohol to get by. And stopping that alcohol flow to some of those alcoholics, they might actually die from it. So what DTs look like is shaking, restlessness, hallucinations, gastrointestinal distress, chest pain, and fever. DTs can be very serious, and they definitely need to go to the hospital for long-term treatment. So if they're having some of these kinds of symptoms and they say they're an alcoholic, but they've stopped drinking 2 days ago, well, that might be what's going on. So you have to ask those questions when a person is presenting like this. All right, drugs. So this is going to be like your street drugs, right? They can be ingested, inhaled, injected, absorbed. There's all these different ways you can do it. Opiates, some people, take pills. Some people inject it. Some people crush up the powder and snort it. I mean, there's any number of ways these drugs can get in you. So some of these drugs, amphetamines, of course, methamphetamine, right? It's an upper. So restless, irritable, talkative, they're going to have lots of energy. In contrast to barbiturates, which are like a depressant, it's a downer. Tranquilizers, opiates, marijuana, stuff like that kind of calms the person down. Now, if you overdose on some of these things, they can actually stop breathing. And we'll talk a lot about specifically opiate overdosing and what that does to a patient. Now, if they're not breathing, you got to breathe for them. And if they don't have a heartbeat, you got to do CPR. It's simple stuff. All right, hallucinogens. These, we don't see them as much as, like, for example, alcohol or opiates, but they're out there. They've got things like PCP, LSD, peyote, mescaline, mushrooms, ketamine, those kind of things. They hallucinate. They see things that aren't there. So not only do they have these hallucinations, they can also have some convulsions. They can go into a coma. Their heart and lungs can fail. They can even have a stroke. So ask some of those questions about the drugs they took, like what did you take, how much did you take, when did you take it. Understand though that maybe they might be seeing something that you can't see. They might be seeing a dragon or who knows what. So they're going to be very afraid, and that means they could be dangerous. You show up in a nice uniform with a bag in your hand and everything, that might freak them out. So that if you get called to some sort of hallucinogen drug situation, just understand it is a borderline scene safety thing, and you got to be careful. So all drug overdoses in general provide basic life support, ABCs. Keep the patient from hurting themselves and other people. Do reassure them. That's one of the only things we can really do in this situation. Try not to judge the patient. I know it's easy to judge them, but some people are hopelessly addicted to opiates, and it's not because they said, I want to do heroin today. It's because they got addicted to opiates from an elbow injury 2 months ago. And they were given a bunch of pills, took them all the time, but now their body kind of needs it to feel normal, and boom, now they're addicted. Their pharmacist cuts them off, or the doctor cuts them off, but they're still hopelessly addicted, so they go to heroin. So you have otherwise normal people who a few months ago were normal people with no issues, and now they're injecting heroin in their bathroom. It really can happen in the space of 2 months. So for opiate overdoses, we want to use Narcan. Okay, and I can show this to you when we come back to school, hopefully here in a few weeks. I actually have Narcan in the classroom. You give it IV or intranasal, and it directly reverses overdose. So a little bit more about our opiates versus opioid. Opiates are natural-ish, as in they come from opium or the poppy plants, right? They're scraped off the plant, they're synthesized, they're sent out, but it's at the base of it, they are opiate-based, poppy plant-based. Now, an opioid is the same idea, but it is man-made. So those are things like fentanyl, hydrocodone, methadone, oxycodone. Those are more of your prescription drugs. That's where you'll see them. Now, to compare the differences between just normal old heroin and our fentanyl and carfentanil, you can see the pictures above and below. You can see how much more powerful these new synthetic opiates are than heroin. Right? Carfentanil is actually used at Fish and Game to take down elk and moose, and people are actually injecting that. One reason that there's a big overdose issue right now is people do heroin and there's actually fentanyl in the heroin, and they don't know it. Their drug dealer doesn't necessarily tell them that. So they do a normal dose of heroin and they overdose and die because it had fentanyl in it and they didn't know it. So just a little bit more about Narcan. It's usually given by like a trained professional, but now anyone can get it from a pharmacy. Police officer can give it. Hell, if you have one in your car and you see a guy next to you who goes down from an opioid overdose, you can give Narcan just on the sidewalk. It's now they've realized there's no risk. A normal person can take Narcan all day, nothing's going to happen. So it's a very safe drug, and it's used only for opiate overdoses. It's a dark slide, so you may have to kind of lean in a little bit and see it. But this is just a picture of how the opiate Narcan situation works. So a person takes a bunch of opiates, and it fills these receptors in the brain. Right now, what can happen, though, is as the drugs fill those receptors, it turns our respiratory drive off. So that means a person will just stop breathing. Well, then we give Narcan. Narcan actually kicks out that opiate, and boom, the person can breathe again. So to show you in a nice Barney-style picture that anyone can understand, basically that heroin's going to try and come into that receptor. Our Narcan is just going to kick it right out. And once you give Narcan on a patient who's not breathing anymore, within 3 seconds, they'll sit up and they'll be breathing and they'll be looking around. So it's a very, very quick reaction. Now, when I was working in EMS in Michigan, if we had a person who was basically not breathing and unconscious, we would just push Narcan anyway, just first thing. It's like, well, we don't really know, so let's take a blood sugar and see maybe if that's what's going on, or let's just slam Narcan, see what happens. And worst case scenario, you push Narcan, nothing happens. Okay, it's not an opiate overdose. But I've seen quite a few times in healthcare where a person's in trouble, you slam some Narcan, boom, a minute later, they're up walking around. It's a pretty amazing transition. So these are some videos. I will also send those out on an email just so you guys can kind of watch them on your own about drug prices and this very controversial idea of open sites. You can watch the video and see what all that's about. So overall, the purpose of this chapter is to really just talk about drug use and abuse and some of those poisonings that we might encounter as we're working in healthcare. So last thing, I know, so it's a little tricky right now trying to do everything online, but I will be there 100% of the time. I'm going to help you out. I will post study guides and lecture outlines and videos and all sorts of stuff. And if you have any questions or concerns about any of the stuff we're covering, you can email me and we'll figure it out. Okay, so I know it's tough, but we'll get through it. I will post the homework. I probably won't have you turn it in right now, like over the internet, but depending on how this quarantine goes, we might get there. But for the most part, just focus on these things I told you to write down and look forward to the test. So as a reminder, we'll have one test when we come back from this quarantine, assuming it's in April. And then we'll have our final during the normal final time, okay? So it's just a few more homeworks and 2 more exams is the rest of the class, all right? So we will get through it. And then as a reminder, if you have any questions or concerns, email me and we'll figure it out. Thanks.